10 seconds, then we'll.
Lokesh,
Yeah.
I think, shall we start?
Yeah. Let's go ahead. Suresh, can you start?
I think the resound is because he has computer and the phone. So you can.
Yes, shut off.
So, one second, I'll just switch off one of the things.
Let him stay. Yeah, in case I need. When share screen, let's see. I can't test now but when I screen share, let me unmute.
Is it all right now?
Yep.
Okay, I think we'll start the proceedings. Okay, I'll just go ahead with I think good evening all my colleagues who are here in India, and good morning to all my colleagues who are in US. It's really a wonderful proceedings that we are on behalf of API. They have come forward to do this particular webinar, important webinar at this particular situation, because we have been listening to several of these webinars on COVID. But however, this is going to be a really practical situation. I mean, the webinar on the real important subject. So for which I thank Dr. Lokesh Idara coming forward to give this webinar to us. So on this situation, I welcome our the president of HAPI, Dr. Suresh Reddy. He is here with us, and also the speakers are here with us. So before I hand over to Lokesh, I request Dr. Suresh Reddy to give his opening remark. Our president, Dr. Vijayendra Reddy, is trying to get in because he was. I just gave all the details to him. The moment he gets in, he will also say a few words. And I request Suresh Reddy to give his opening remarks. Everybody are able to hear, you know?
Yes, yes.
Right. There, yeah.
Suresh.
Thank you, Dr. Dwaraknath Reddy. And this is an amazing interaction, educational event between India and United States. United States is ahead of the curve or on the downslope, and it's so it's a very interactive. This is part of one of our webinars. We have done more than 30 webinars in the last 3 months, and COVID, as you know, has hit us hard, surprise, shock, but we are hitting it back. We got it under control. There are several treatments that came on the way, but that one treatment you are going to hear today is one of the most well-established over decades, least expensive way of treating these patients. And thank you for joining today. And the topic today is early corticosteroid treatment for COVID-19 patients to prevent hyperinflammation on an outpatient basis. We have speakers, Dr. Anes Suresh from Michigan and Dr. Janaki Kanumilli from New York. And we have the moderators, Dr. Lokesh Idara and Dr. Dwaraknath Reddy. I convey my thanks to my counterpart from Telangana State, Dr. Vijayendra Reddy. And Lokesh, please take it over. Thank you.
Who is Dr. Kata? I cannot, I think he took the screen off. This is Lokesh Idara. Thank you so much, Suresh. I really appreciate your giving opportunity to API for give this opportunity to share our experience, what we are going through for last 3 months. I will just say a few. One of the good things happened is we've been struggling with steroids, early steroids. It's a hyperinflammation, which is killing our patients, not the virus. So we asthma doctors, so we're treating the asthma inflammation for a long time. So yesterday, Dr. ICMR came up with guidelines, including the methylprednisolone in moderate COVID patients. So that is really a breakaway from WHO, breakaway from CDC. So we really thank ICMR to take up the step. So we also are requesting IMA to help to pursue this even earlier on outpatient and as an inpatient. I'm going to introduce our first speaker, Dr. Janaki Kanimali. She's practicing since 2011 in New York.
2001.
2001.
2001.
Thank you for correcting 2001 and more than 20 years. And she's a graduate of Belgaum Medical College and she's board certified in family medicine. She treating the patients as an outpatient and also inpatient in a nursing home. Nursing home means it's just IV fluids, just very basic. Any Indian private nursing home facility is equal to nursing home in USA. She will share her experience, how she saved money more in her situation. So with that, I will request Dr. Janaki Madam to start and take the share screen. And thank you so much. I really appreciate it.
One word. She is from Medical College, I think Belgaum, isn't it?
Right.
Yeah. So she did her MBBS from Belgaum, and
Yes.
she did as radiology from our Nizam Institute of Medical Sciences.
Oh, very good.
This is a small sort of a slight introduction I want to give to Dr. Janaki. Please take over, Dr. Janaki. Thank you.
Dwarakanath Reddy garu. Hello.
Vijayendra వచ్చారండి లైన్ లో. Janaki garu, sorry for small disturbance. Our president is on the line. Yeah, Dr. Vijayendra Reddy is on the line. So he will just say a few words before Dr. Janaki takes over.
You're seeing my screen?
Go ahead.
Namaskar. Can you all hear me?
Yes.
Yeah, very much.
Yeah. Good evening, all the friends in India, and very good morning to all the friends in USA. And I'm Dr. Vijayendra Reddy, President of IMA Telangana State. And this webinar especially is organized jointly by the Indian Medical Association Telangana branch as well as AAPI. And as all of you know, COVID now it's a pandemic situation affecting more than 200 countries across the world. And doctors as frontline warriors, they are really doing great sacrifices, and it is being applauded and recognized and acknowledged across the globe. And now doctors are always students. A medical student, he needs to upgrade himself every time, each time. And therefore he needs to participate in conferences and webinars like this, especially in the present situation like this. And he needs to develop his skills both in art as well as science of medicine. And the topic that is for today is a very useful topic, and I think all of you know about it. And we've got a very good speaker today, regarding whom the introduction has already been given by my counterpart from AA, Dr. Suresh Reddy garu. I thank Dr. Dwarakanath Reddy garu as well as my friend Lokesh for getting me involved in this. And thank you so much. Thank you.
Okay. Thanks a lot, Mr. President. And over to Dr. Janaki.
My screen?
Yeah.
Hi. Hi.
Yeah.
Good morning for people in USA and good evening for the people in India. Thank you for the API leadership for arranging this program. And thank you, Dr. Lokesh garu, Dwarakanath Reddy garu, for training me to do this talk. Okay. So basically the timeline of COVID, I'm not going to talk all the symptoms because everybody knows by now. In my outpatient practice, the most common complaint is dry cough and loss of taste and smell. And rest of the symptoms follow with body aches and cough, itchy throat, headaches, diarrhea. So why steroids? Why I came up in the later part of management, why I thought steroids were helpful. Initially, I have an outpatient practice, which is like 5,000 patients. I had like 26 asthmatic patients and 18 patients called cough with fever. I just gave Z-Pack and told them just to do your inhalers and you'll be fine. And COVID testing was done on those patients. They were all positive, but they got out without any issues. And 11 progressed to wheezing and shortness of breath, for whom I started steroids, antibiotics, and inhalers. All patients recovered. There were no chest X-ray changes. So I was happy, like it works. So my other part of the practice is nursing home practice. I have a large population which I deal with. My total nursing home residents are like 220. Most of them are age group 75 plus. Very few I have in 60s who have behavioral issues. Out of these 220, 190 tested COVID positive, but this happened over a course of time because this has come like in waves. Starting timeline March 25th to April 10th. Out of these 220 patients, only like 38 developed fever, shortness of breath. At that point, our protocol given by Department of Health was hydroxychloroquine, doxycycline, IV fluids, oxygen. 20 went into hospital, 18 of them died. So next timeline was from April 10th to 30th. Things were changing, and even hospitals started changing the treatments. So around 50 patients at that time with symptoms, I had the next wave of patients. And I did the same thing. At that point, we started monitoring the pulse ox very closely. Everybody was on oxygen, everybody got hydroxy, everybody got fluids. And at that point, we started giving steroids where the respiratory rate went high, up to 30s in some patients, and we started the steroids. And then that wave, only 5 patients were transferred for high flow oxygen, and all of them survived. So in this group, only 2 died, but because they were very complicated, they had end-stage renal disease, dialysis, hypertension, diabetes. So coming to May, we were a lot better. I had rest of the crew who developed the symptoms, again, started with fever, then little cough, in a week progressed to shortness of breath, and pulse ox, interestingly, drops from 99 to 95 to 89. Overnight, patients had pulse ox dropped. So then implementing the steroids, at that point, I added blood thinners, Eliquis also. So then patients, I did not send anybody to the hospital in the last batch. And last 20 days, I had not a single positive COVID patient in my nursing homes. And I started seeing patients in the office. I have not a single patient with symptoms. So, so the reason we are talking today is how we avoid hospital admissions. The other thing is in the nursing home practice I have is similar to India, where you get nursing care, IV fluids, steroids, chest X-ray, all this can be done in the nursing home. Pulse oximeter, high flow oxygen, everything can be done. So this could be done in India also in a smaller nursing home setting. And patients need not run to big hospitals, corporate hospitals, because it can be managed by the primary care physician at a community setting. And initially when we started, the WHO and CDC said no steroids. Even in our hospitals, we did not use steroids in the initial phase. When the Italian study came up, when it's microthrombi and it's a lot of inflammation, that's when these anticoagulants and steroids came into picture. So basically, we can divide this COVID infection into stages. So stage 1 is early phase, early infection. This is the viral response phase, where all your symptoms come early, like fever, little bit of dry cough, body aches, myalgias, everything. And 80% come out of this stage with early intervention, just taking a lot of fluids, just walking every day, And these patients do well without much intervention. The next phase comes in this stage 2, where patient says, patient can count the respiratory rate. I think that could be the easiest way in India to diagnose early like onset, where the lung is affected. So at that point, if you start steroids, then the inflammation gets better, where the disease progress doesn't go to stage 3, where you need much higher steroids at that point. So I think from my perspective, once the patient says, my cough is not breaking, I'm short of breath, and at that point, I'm ready to start steroids. So the lab work is routine, CBC, CRP, ferritin, LDH, AST, ALT, D-dimer. So the role of D-dimer is important because that's where your anticoagulation comes into picture. But if you are treating as a community physician, we do not have all the luxury of getting D-dimers, and the labs take forever. So my goal was just to prevent the cascade of this thrombosis development. So whenever I started steroids, I basically started them on anticoagulation also. I did Lovenox for 3 days and switched them to Eliquis after 3 days. And so treatment protocols are same everywhere. Generous hydration, that's the key for this disease. And treating the fever with Tylenol or paracetamol. Initially, they said to avoid NSAIDs, but I don't know. I think we can use them. That's not a problem. And we tell patients, you need an antacid. You have to walk at least 100 steps every hour. You always put them on an antibiotic. Azithromycin is very common, or doxycycline. So, but my favor was doxycycline because I used hydroxychloroquine in the beginning, but now we are not allowed to use in the United States. So back then I used doxycycline instead of azithromycin because together they prolong the QT interval. Again, when you have azithromycin and hydroxychloroquine, we need to monitor the EKGs. So in a nursing home, to get an EKG, it's not an easy task. So that's how I switched to doxycycline. And then we advise to take zinc and magnesium supplements. So that's the first part of the talk. And the second part comes the risk factors for thrombosis. And it is, again, the sedentary lifestyle, patients who have other issues going on with him, and the disease state itself causes thrombosis. It is interestingly, it's both arterial and venous thrombosis. I had a 68-year-old female just doing fine. Suddenly she develops shortness of breath. I transferred to the hospital. She was found to have a big clot in the right atrium, and she died. And maybe it would have, early on, if I would have put on anticoagulants, maybe I would have saved her. So according to protocols, according to ICMR, I was reading to their protocols also, what you are following in India for mild COVID symptoms, fever, dry cough, myalgias. We advise, same like here, advise take Tylenol, paracetamol, drink plenty of fluids. So moderate disease is when you're in the second phase of the graph, where you show your mean pulse ox is 94%, but everybody does not have a pulse ox back there also. So you can just, assuming the patient says, I have difficulty breathing, you can tell them how to count the respiratory rate. And if you see that he is tachypneic, then at that point, the patient needs steroids. And usually the target oxygen around 90 to 96% is preferable. But in US, at the peak of the epidemic, we have seen oxygens at 89 and patients were totally fine even at 85. So it looks like the body adjusts to whatever changes happen in the lungs. So So periods of venous thromboembolism, risk for COVID-19 patients. This is the hospital side recently I saw, and then they say they put all patients on anticoagulants once the patient goes to the hospital. But as outpatient, we also can do the same treatment. Our whole idea is not to send to the hospital in United States. So it should be the same protocol in India where you treat early, you avoid hospitalization, and it is very good for the family and as well as the patient. Next, this slide is very important. You have to educate patients, the prone position. You explain to them laying prone at least 4 hours a day. The patients who are having shortness of breath, they should be able to do this and their oxygenation markedly improves. We've seen pulse ox going at least from 90 to 95 just by prone position. So, I mean, these are basic things. We can train patients. We can train by video call. You don't need to see them. Throughout my 3 months with dealing with COVID patients, all the office practice was dealt with video call and telephone call. So I think we can do a good job by just learning from each other and training other doctors and doing this in massive way. So we avoid a lot of admissions in India, and I think that's all I have for now. Thank you so much. Thank you for the RP team to allowing me to participate. Thank you.
Thank you so much, Janaki. So Dwarkanath, can you please introduce our next speaker, Dr. Suresh? Can you hear me? Can you hear me? Yes. I think you need to unmute Dwarkanath, Vijaya. Yeah.
You're able to hear now? Yeah.
Yeah, go ahead, sir.
Yeah. First of all, I should thank Dr. Janaki for her practical way of doing things. I mean, also the simpler ways that she has put forward. And you can put any of the questions later on after Dr. Suresh, when he finishes his lecture. You can take up some of the questions also. So now I think we'll go to the next speaker. Is Anish Suresh, MD. He is the Associate Professor in the Division of Allergy and Immunology, the Michigan State University, Flint campus. And he is a fellow of several other organizations over there and practicing allergy and clinical immunology for the last 27 years. And also I would like to inform you also, he is the product of Andhra Medical College, Vizag, and he is from he hails from Krishna district. So this is his background. I request Dr. Suresh to give his presentation. Over to Suresh, please.
Thank you, Dr. Garu, and thank you,
Suresh, 1 second. I want to add, Suresh has treated his own family, and he spent 48 hours in ICU with his father. Unfortunately, he lost his father, and his passion being an immunologist, and he saw 50 charts in his hospital. And there is so much emotion involved in this. It's been a journey of 3 months. I just like to add that for viewers. Thank you, Suresh. Go ahead.
Thank you, Lokesh and Dwarkanath Garu. And yeah, this is actually a more close and personal to me for treating the COVID. And since I lost my close family member, I'm really looking into how this is happening and what can we do. And during the process, we have developed some protocol in treating my patients, which I can address. And thanks to Dr. Janaki Garu for a elaborate practical view of looking at the COVID and to treat that with steroids very early in the course in her patients and saved many patients. With that, and I will, even though, I mean, she really elaborated how the practical things to do. I want to give my view of why we want to start the treatment with the steroids from the early onset. So let me share my slides. Sorry for the delay. What is the disease spectrum of the COVID? We all know the incidence is high, even though we're not testing everybody, but most of them are asymptomatic, right? About almost 80–85% of them. And some of them are the symptomatic, but self-limiting disease. It's not going to be into everybody is going to be in the ICU. Up to 10% of these patients, they get really severe symptoms and get admitted in the hospital. Half of them end up in ICU with cytokine storm, ARDS, whatever that we are talking about, extensive alveolar inflammation or hyperinflammation, many names floating around. And this, in this subgroup, is the one that is causing the death rate very high. That's what we call now secondary hemophagocytic lymphohistiocytosis, as far as the allergy immunology concerned. And this is the condition, I think, once patient get into this situation, it's very difficult to recover because all the information is in set and all the organs are in failure. I just want to put this slide to understand what's the inflammation and how the cytokines work. If you look at this, multiple cytokines, even though for immunologists, it is many times confusing. IL-1 and from IL-1 to IL-18, many of these cytokines involved in, and many more that we don't know. Not only the cytokines, there are chemokines, adhesion molecules, and other cells that are involved in inflammation that causes significant damage to the cells as well as organs. You can see here that chemokines, how they traffic in these lymphocytes to different places. These are the adhesion molecules that are highly expressive, especially when you are infection. And these are all endothelial cells in different organs. They attract lymphocytes. Lymphocytes goes to the site of inflammation and destroy the tissue. So when you look into this SHLH, there are multiple factors. So what is the factors that we have to address? Now, how we can address all these factors? That is very, very important for us to treat the disease or to prevent the death rate. You can see the inflammatory cells, the CD4, CD8, CDR-TH17, CD8 positive cells, macrophages, monocytes, all system, the whole immune system is in the high alert. Hyperinflammatory condition, multiple cytokines, chemokines, and adhesion molecules involved. Not only that, all these inflammatory signs will result into the proteolytic enzymes, leukotriene agonists. They cause the damage to the cells. They also cause the damage to various organs. And we also know that the oxygen carrying capacity is going down. That's because of the protein unfolding. The protein folding was also disrupted in the RBC, in the Golgi apparatus. All these inflammatory markers, inflammatory cytokines, and the cells causing coagulopathies and multi-organ failure. We all know now, we thought initially the children are not affecting, but now we are seeing more from the New York. The study came in as Kawasaki-like disease present in the children, which is more, we know that Kawasaki-like syndrome occurs in the previously in viral infections, and that is mainly due to the inflammatory reaction. So this part of it, this last part of it is SHLH, or the cytokine storm, or the hyperinflammatory condition, is not from the viral load, or it is not from the virus itself causing. This is the body's defense. Body is fighting against the virus. But once that is over, body forgot about how to stop the response. So there is the inhibition of that response not there, so they become into keep going on hyper-responsiveness. Our immune system itself is killing ourselves. So it's a more of a damage that is occurring, collateral damage, that you throw a carpet bomb and you're dying. Not only the purpose, that exact enemy, that you're killing the whole population. So if you take that analogy, this is really the one that is causing is body's inflammation against the virus, which is uncontrolled, then resulting into the hyperinflammation and death of the patients. The majority of the death occurs due to that, because of the damage to the endothelial cells, damage to the multi-organs, including the heart, kidneys, and the liver. But we are seeing it is an early bit, all over the lungs were inflamed, and alveoli, everything is inflamed, so you're not able to breathe. So before it gets into the other organ damage, we're already seeing the patients are dying. So how can we treat it? We've been focusing on antiviral drugs to show that will decrease the viral transmission. Remember, all these drugs, by the time we're using it, these patients are already in the hyperinflammatory stage. They're already in, the virus is not a problem there. Even if we stop the virus, what is that we are doing? Every one of these drugs we are addressing is to control the virus or virus spread. Of course, that you can see the hydroxychloroquine, the story going back and forth, even though it is some anti-inflammatory effect, it is not very effective anti-inflammatory drug to block the whole reaction or to control it once the inflammation sets up. The same thing happens if the convalescent serum. Yes, it does address, but the patient is already in the hyperinflammation. He already has a damaged lungs, a damaged heart, damaged kidneys. So how that is going to address that? It's not going to recover it. That's why it is very, very important to address the whole thing. Just an analogy, I think in the last week when I was talking to one of our colleagues, gave it is, yes, this is like, we are cutting some branches on the trees, but the whole tree got fungus. So what are we going to do? So I went through the literature, and when I see some of the articles, especially Dr. Meduri, who gave an extensive, detailed lecture about a couple of weeks ago in the same meeting when we were doing on the API. I think you all can probably have to go through that study and really look into what he's talking, and you can understand. Why steroids? I mean, if every one of us know that go through the medical school, steroids stop the inflammation. And it has many ways of doing it. One is it attaches to the glucocorticoid receptors, where it blocks any synthesis of RNA or any synthesis of DNA. And the matter of fact, it will stop the transcription of any DNA or RNA, and also it stops the production of protein by blocking the protein synthesis. And it also produces, now we know more of if you look into the level 3, where there is non-codon RNAs which are produced, so which will block, that is one of the RNAs that we notice that blocking the protein synthesis and the spread of the virus, etc. And the mRNA stability is also reduced, so the mRNA will not be producing or carrying the messenger. So it's just this slide I put it in because you will know where the steroids working. The steroids are working in the nucleus, and it is blocking the complete synthesis of protein as well as the nucleotides. And if you go to clockwise from starting with the macrophage mediators, which are blocked by the glucocorticoids, and lymphocyte mediators are reduced. Mast cell members as well as the inflammatory cytokine release were reduced. Respiratory epithelial cells production of mucus and the damaged various mediator release, everything is blocked. Same thing the capillary endothelial one, which is, you all know, most of these patients developing damage to the capillary endothelium and also causing all the intravascular coagulation and all the clotting, etc., etc. So all these things, now we know that glucocorticoids block it or reduce it. If the inflammation is not heavy, it will reduce, but in cytokine storm, we have seen intense inflammation all over the body. So whatever we would think, we treating with the anti-inflammatory treatment. We all know that now everybody is getting on the fancy IL-6 receptor blockers and IL-1 blockade, and all the monoclonal antibodies is the go-to drugs for these days. Remember, these are the ones that address specifically one single cytokine. I agree, if you want to treat with these drugs, they can address one single cytokine, but the problem is not stopped with one single cytokine. We have multiple cytokines, multiple chemokines, and multiple inflammatory proteins that are damaging the tissue. So if you look into the whole scenario, now you understand, not just cutting one or two or three branches, we're not going to stop the whole fungus that is spreading around on the tree. So the corticosteroids, if you take that's one we notice that it will really stop the inflammation. When to start? The question comes in, and after the last talk was, many calls got it, when to start the steroids. So now everybody is nervous. As we all understand, everyone is nervous about to use the steroids. And I'm glad the ICMR came on, at least they put it in a high-dose steroids for 3 days. But I don't know the reason why they do want to stop the steroids at 3 days. I hope that once we get the data, more and more data coming in, they will address giving it a long-term and at least starting the steroid. So I want to go through here my clinical experience before I further discuss on that. I have treated, and in our office, we treated about 30 plus patients from different areas, ages between all over from 12 to 84 years, both sexes, and 1/3 of them are above 60 years. As we all know, above 60 years are very highly prone to develop, the mortality is high because of other comorbid conditions. Out of that, eight patients of mine, severe dyspnea, that's less than 94% are roommate, and 10 patients have cough with exertional dyspnea. So 18 patients of them, they are in the dyspnea state. Most of them with persistent fever and body pain. These symptoms presented between 2 to 2 weeks. Most of them recovered within a week of treatment with corticosteroids. It's about almost 65% of them, even though after treatment, you see the antibodies were negative. This goes along with other studies that were done that is coming from Sweden and other areas. The antibody production, again, is not 100%. So that what it means, we may not develop herd immunity. And we know the experience from London after multiple deaths, that now they realized it is not probably herd immunity is not a good idea. Treated with 1 to 2 milligrams per kg per day in 2 divided doses. It's morning and evening. That's a common thing that we start with because I usually start these patients very early in the course. An antibiotic that just, I think, I'm not sure there is any information about they treat anything. It is just using along with the prophylactic steroids, especially when they are sick and fever. We don't want to just leave it there, not thinking that other infections are not there. So that's mainly we treat them with antibiotic to just cover the bacterial infections that may spread. Paracetamol for a fever. I do not use NSAIDs because of the initial reasons. Again, now we're not sure, that can be debatable. And H2 blockers, like there's a paper came in as a famotidine as an advantage, but that was not the reason we started using the famotidine or cimetidine. These are the H2 blockers, which we use to prevent as a gastritis prophylaxis for those who are on the steroids. And then make sure generous hydration. These patients are outside, ambulating, so you cannot heparinize them. That's why I want to make sure they have a very generous hydration, because the hemoconcentration also contributes to the thrombus formation. Frequent walking and rest is very important. Monitoring of oxygenation, which is a simple test, just by doing the pulse oximeter. The reason we would like to, I'm insisting on the monitoring oxygenation, that is one of the earliest signs I find very useful to predict any future development of the heart if they are getting into the hyperinflammatory state. So when to start the steroids? This is a $1 million or $1 billion or $1 trillion question, but I recommend to start them as early as possible, just to prevent them to get into the state, because it is easy and the dosage that we use is lower than patients are already on the already into the cytokine storm or hyperinflammation or SHLH, whatever that you name that whole thing. There's a persistent cough and severe headache. That's one of the early signs that we see. Exertional dyspnea. Why I'm saying the exertional dyspnea here? Pulse ox may be normal in the regularly, but when they walk few steps, don't even have to do many, about 15, 20 steps, the oxygenation level drops to less than 94%, which I find is a very sensitive indicator for anyone to think about the inflammation started affecting the alveoli. So that is the time you can stop immediately there. Cytopenia, lymphocytosis, lymphocytopenia, monocytopenia, thrombocytopenia. This is pretty commonly we see. The reason that we see lymphocytopenia and monocytopenia is infection with the virus. The virus is killing here these lymphocytes and monocytes. They are dying. So going down, or lymphocytopenia or monocytopenia will probably not a bad thing. But when the lymphocytes started coming back, a sudden increase in the lymphocyte count, which is from say 400, 500 to 2000 or 1500, that is not a good sign. That is a sign that these cells have started coming back and rigorously, and the body was taking over the inflammation, started the inflammatory cytokines and releasing all of them, leading to the hyperinflammatory state. So I want you to understand that don't worry about lymphocytopenia. Lymphocytopenia is in fact I'm seeing more and more, is a status where you are in a good condition. You can start treatment at that time, so you can prevent it. Elevated C-reactive protein or ferritin, D-dimers, LDH, LFTs, all these things. So we are already into the inflammatory states once we started seeing elevation. So any of these things started elevating, you have to be very, very careful and be addressed. And there is a H score that they put all these things together. Numbers from one of the physician from London released it, so I can, if anybody interested, I can send that information. How do we treat it? The most important thing is a corticosteroid to start as early as possible. People asking me in the last month, when do I have to stop the steroid? If you think that the patient is having infection with the COVID-19, I will send them all the lab work and immediately start the steroids, not even waiting for the results of the COVID. Because as you know, after third day or fourth day, the COVID test, even PCR test, is only 60% positive. So you lose about 40% of the patients we don't know, the negative. So they are falsely negative. So I want you to be very, very aggressive on this. Many patients that we think that whenever they come in, you think that they have the symptoms and they're already send the lab and start them on the steroids. There is no harm is done. Oral H2 blockers, that's just we talked about why we are using, and the other things are all we explained. Unless if they have a D-dimers elevated, then it's not necessary to treat with anticoagulation. Or if you want to give them just a oral platelet agents like clopidogrel or something, it will be fine. Multivitamins, zinc, magnesium supplements, these are all very helpful as adjuvant. Generous hydration, ambulate frequently, and prevent the clotting. We'll try to avoid the intubation as much as possible. Even the patient in the hospital, that by supplemental oxygen with the prone positioning, we can control if we are adding the early course of steroids and other anti-cytokine medications. So that antibiotics, hydroxychloroquine, antiviral medication, these are all the things, never proven. They're never yes or no, it's all debate, even the cytokine antagonists. But I do ask them, once they are in the storm, once they have elevated IL-6, and these things you can probably add it as an adjuvant. There is no harm. While you're treating with the steroids, you can still treat with these medications. And the studies were still waiting. There is a study that is going on with a different combination of the drug. So until that study comes in, we can use whatever that is available. But in India, like our society there in India, where it's very difficult to get these drugs, especially for the mass public, if the cases started coming more and more, it's very difficult to available for everybody. Another question that everyone is asking about the corticosteroid side effects. Corticosteroid side effects are, as you all know, we all treat with the corticosteroids, especially for the asthma. And most of the pulmonologists in India were very well aware of corticosteroid side effects. If you are treating the asthma aggressively, even with the viral infections, we treat them with steroids. If you take about another, really everybody is bothering is what happens to viral persistence. Yes, there is a study that shows that viral persistence is there longer period, the persist, but we don't know what it means, and it doesn't relate to the not able to control the disease, or it is causing any disease worsening. Absolutely, we did not see anything. Another evidence that I can tell you is many of our patients, when we are treating with asthma, when they get a viral infection, when you get the asthma exacerbation, treat with the oral steroids. But we're not seeing any virus spreading and causing the pneumonia in those patients. So I do not worry about the viral persistence, because there is no evidence that persistence of the virus is causing any problem. The relapse of the infection is very important that we were thinking about. When I stopped early in the beginning, the course of the steroids, about 5 days or 1 week, I've seen few patients coming back after a week with, again, the symptoms recurring. So I'd rather extend the steroid use for 2 to 3 weeks than stopping early. All said, social distancing, wearing the mask, hand washing. Those are the things that we always have to follow and tell, and then be safe and good luck. I'll be happy to answer any questions.
Thank you so much, Dr. Suresh. I really, really appreciate it. So we'll go for the question and answer. So I think one of the common question, I think you may want to answer, both speakers. They have the steroids, so when to start, which you answered, but there's one question is, Janaki Garu said that it's a pulse rate. Like if I'm a small guy, I don't have pulse oxidizer. Is the respiratory rate 24? Can you answer that? And Janaki?
Yeah, basically, because 70% patients don't get into seriousness of this COVID infection. A lot of them are getting better without even intervening. Maybe I gave some Z-Pack for some of the patients, but a lot of them don't develop respiratory distress. The moment, as Dr. Suresh Garu said, the patient says, I can't walk even one flight of stairs, or I can't take 5 steps, I get short of breath, that's the indication for steroids. For a practical point of view, if you're in a hospital setting, obviously your pulse ox is the cutoff, 94%, then go ahead with the steroids. So that's what we've been doing. Like, I don't give it on the first day. As I said, 70% get out of this disease without any problems.
Suresh?
Okay. So one of the thing I think probably everyone know is the happy dyspnea. You probably that's the word that is going on around. The people, it's not a question of happy dyspnea. What people say is whenever you are sick, you feel lethargy, you feel tired, so they don't want to get up and walk. That's not because of their any other weakness. It is just they cannot. They dyspnea. They, instead of expressing that they have dyspnea, they just say, oh, "I'm not feeling good. I'm tired." That itself is a sign that you need to look for. That itself qualifies you to think about this is getting into the inflammatory reaction. So watch for those subtle signs rather than depending on just the numbers. And you can ask, just as Janet said, I agree with her, just to see a leak. It's definitely something to guide is having a tachypnea, and patients are just lying down, not walking, or when they're walking and they cannot do. Just to give an example, for me, my personal example, when I was infected, and I had 2 days of, I usually do about 45 minutes to 1.5 hours of treadmill. Those 2 days, I could not do more than 5 to 10 minutes. With 5 to 10 minutes, I get so short of the dizziness, I couldn't do it. I did not recognize that was probably the reason. So one should be careful, especially in the elderly people, those who are in the nursing home, they do not walk, they do not do things. So how can you diagnose the dyspnea? So itself, that they're not feeling well itself also is a kind of dyspnea, I think.
The next question is the tapering of the steroids. We know in asthmatics, we taper most of them in 5 days. So I think my personal is at least 2 weeks to sometimes longer. Can you mention how long is the steroids, how long it takes in your experience, most of the patients?
Most of the patients, it takes about a good 2 to 3 weeks. I have a couple of patients, I treat them almost 5 weeks, but it's most of them with a significant dose of steroid. Actually, you can think about 1 milligram per kg twice a day for up to 1 week. Then we can taper it down, but I will really follow the clinical lab work that we want to follow, especially looking in the inflammatory markers that whatever that we have available there, we can use them and then follow on that. One specific thing simplest thing that any lab can get is a CBC differential, especially the lymphocytes. If the lymphocytes are going up, watch for it. If you want to push on the steroid dose to even up to 125 milligrams of solumetrol every 8 to or every 6 hours, go ahead. And especially if you are starting this medication or the prednisone, when they set up the inflammation, then you need to go very high dose for at least temporary.
What's the preferential, the steroid you prefer?
Most of my ambulatory care patients are treated with prednisone, and they recommend methylprednisone. We all know that the prednisone and prednisolone that converts into methylprednisone in the liver. So maybe if they have a liver damage, that can be a problem. But I do not really worry about which prednisone that you are using. But I stick to either prednisolone or prednisone or methylprednisolone, all of them. Okay. Only the drug IV you can use is methylprednisolone when they are in the hospital. So you can pick it up anything.
Another question we have is a patient say a very mild irritation in the chest, but they have fever and diarrhea in 2 weeks. Is the steroids respond to those treatment in your experience? That's a question in the chat box.
Yes.
So definitely.
Yes.
Yes.
I have another comment to say on the length of steroids. So now I'm seeing patients other side of the curve. I get patients from hospital discharged, and the steroids are done, but a week or two in the nursing home, I see another flare of respiratory failure. So I go back on the steroids again. But nowadays, patients are discharged on anticoagulation. So the mandatory rule is 4 weeks of anticoagulation after the course of the disease. So I feel the steroids have to be a prolonged taper for 4 weeks at least to avoid another storm coming. I mean, I have seen few patients, I don't know, maybe in the next few weeks, it'll be a lot more. Any comment on that?
Yeah, let me also add one more point, Dr. Janak Garu. I think one of the problem that we are seeing or we are going to see sooner or later is the fibrosis.
Yeah.
If we're not controlling the inflammation very early in the stage, there is always the risk of developing fibrosis, and the pulmonary fibrosis are going to be a major problem in the long run. So I really would like to continue steroids at least 3 to 4 weeks to address the inflammatory reaction of the complications in the future.
And to add this, those patients who are off the ventilator or 3-4 weeks of ICU, they are, I think, probably around 3 months on steroids. And also don't afraid to be on steroids. I spoke to Janak, your husband, Jagara, he's an anesthesiologist. I'm sorry, neurologist. They treat for our Bell's palsy and all other things. They treat minimum 1 month, they taper out 2-3 months. So we're not talking about steroids for years and years. We're talking about a few weeks. So that's what other people's input. Dr. Moderator, can you ask questions?
Yeah. The thing is that somebody has asked about the dosage in pregnancy. I think one of you can take it. So
We don't want to touch the untouched territory because pregnancy is totally obstetrician's choice.
Oh, no. I can answer that. I can answer that question. I can answer that because we treat asthma in pregnancy. In asthmatic flare-up, we treat with steroids. I have patients taken 9 months of prednisone. The third trimester is pretty safe. If they need it, if they are unfortunate, if they get it, I would not hesitate to recommend. If I got consultation, I will go ahead and give steroids. This dose of steroids is nothing. Actually, it will be pretty safe. Actually, it will help if a premature baby, it helps the lung. They do treat with dexamethasone like before. So we can ask neonatologist help there.
Again, in diabetes mellitus. So because they usually they don't go for steroids. Now this is the place where they do give a lot steroid salts in diabetes mellitus. So there's few words about that because most of the patients they do have the diabetes.
Yeah, but you can put them on sliding scale insulin, or you can put on long-acting insulins, and you can adjust the dose according to their blood sugar. It's not hard. It is just the requirement is higher than regular diabetes. When they're doing regular care, you just add more insulin as you put them on higher steroids.
Let me ask a different question. If you have a diabetic patient, which is many, if they have asthma flare-up, do you give steroids or you don't?
You give,
there is no simple as answer. Here, asthma patient, you have time, but this COVID, you don't have time. 8 days, you're on ARDS.
No, I think that's a pretty common question in the last 2-3 weeks since our last was about the diabetes and people worrying about diabetes. I know I have my close friends that calling me about the diabetes. And it's easy to treat the diabetes. I mean, if you think about it, it's very easy to treat the diabetes, especially in the acute state. You're not working on long-term problems of the diabetes here. With blood sugar, as long as you control the blood sugar with the medications, with insulin, you can safely treat it. But if you lose the time for the inflammation, you're going to be really in big trouble. I'm seeing one other question that is on the audience. If you and Lokesh, can I take that?
Go ahead.
The question that was very interesting question I saw that was seeing about the neutrophil lymphocyte ratio has anything to do with the inflammation, etc., whatever that we're talking about. I know everyone is talking about, but the inflammation causes elevation of all these cells. What we are saying initially is when there is an infection with the virus, you will see the lymphopenia. You can see it not only in COVID, you can see it in other viral diseases. You can see it in the influenza. You can see any viral disease, you see the lymphocytopenia. They don't affect the neutrophils, okay? And the neutrophils naturally goes up because there is some inflammation. They're scavengers. They want to clean it up. So you produce more. Any lymphokines and cytokines that causes an increase in the neutrophils. So what does it mean? The disturbance in the ratio, yes, there will be lymphocytes low and there will be neutrophils high. But I'm concerned about is when the lymphocyte starts going up. When the lymphocyte starts going up, that means The body is responding and body is pumping into all the cytokines to release, to increase the lymphocytes, which is not a good sign. This is the observation that I have noticed in inpatient. It's observation that I noticed in my in outpatient. And I think, I don't have much in which subpopulation of lymphocytes are increasing, but that is one of the things we should look into. Is it a helper cells or is it some of the specific NK cells? There are now some literature coming in LK cells and lymphokine activated killer cells, etc. They might be going up. We don't know at this time and how to address that. So at this time, for our practical purpose, simple thing, CBC with differential, which lymphocytes, as long as they're going down, holding down less than 500 or less than 800, you are in the safe period. You can start your treatment. If it starts going up, then you have to be really rushed it and you have to go into the higher dose of steroid. You really knock it down. That's one other thing that I noticed in the last month. We're seeing that lymphocyte problem. So don't worry about the ratio. You just monitor and follow on the lymphocytes and monocyte.
Somebody asked about the question of the role of aspirin in severe COVID. This is not that it could, maybe because of the fact that we are talking about the thrombocytopenia. So
we do not have any good study that whether it is safe or not. Initially, we thought about that there is some issue about the spike protein, the increase in the receptors, and then increase in the viremia when they were using the non-steroidal anti-inflammatory drugs. So we don't know. Now, I think recently they say that probably the non-steroidal anti-inflammatory drugs may be useful when the patient starting having the inflammation. Because as you know, if these are all some of the blockades of the leukotrienes, etc., they may help in the later stage of the course. We don't know. It may be an adjuvant. But if you are using that for platelet adhesion problem, you can probably use a clopidogrel or some other drug that can be used at this time safe. So that is the only reason I'm not using the NSAIDs at this time to control the fever or using as an anti-platelet drug.
One more, I want to do the API disclaimer for this teleconference. I think we played and displayed. The service of API COVID-19 teleconference is for information purpose only, should not be considered as medical or financial advice. I'm sure it is also coming from IMA too. API has no liability as how this is interpreted, no liability for results, losses, damage that may be caused directly or indirectly or incidentally. Please refer to in USA CDC website and use your state government health authority for information updates. And in India, of course, ICMR and state governments. Period. Thank you.
This is something like a statutory warning, like smoking is injurious to health.
Well, we have to.
I know. Anyway, we have to understand that. But anyway, see, in fact, see, one small comment, I think. So the Italian model, how it has come also, everybody are aware of it. The real fact is that is producing so much of hyperinflammation, having so much of mortality was going up, and that started using the corticosteroids. I think drastically things have come down very much. I think this must be the role. I think you have to look into the future perspective of taking of these COVID patients, whether any of the places. Is it so? The role of this corticosteroids and we need to start as early as the third day, isn't it?
Yeah, as early as you see the patient. If you're suspicious about the COVID, send the lab work and start the steroid.
I have a doctor in our town. He starts with as COVID positive. I mean, we get the results in 12 hours. I'm sure if the patient came to you, get it tested means they already know. So high suspicion, and 30% are negative. They don't put up the strip all the way into the nose. So that's why the test is not conducted. That's one of the major reasons. Gandhi, I spoke to the postgraduate at Gandhi Hospital. Sir, 70 people come, 50% are positive on the day one. They stay in there 2-3 days. They're all positive. That's Gandhi postgraduate told us. So if you have high suspicion of symptoms, there are enough 5 days of steroids. I don't think you go wrong or you don't do anything negative. That's for sure. There is mild cases, what should we do? I mean, if the symptoms mild cases, looks like at least steroids is good. Suresh, what do you think about mild cases? I don't know how to differentiate mild to moderate.
You know, Lokesh, if any patient that is coming to you for seeking advice, I don't consider it as a mild. Okay?
Yeah, it's all
They
moderate.
have some symptoms that are alerting them to come to you. Okay. But the question comes in, the main question probably you should be asking is, we know once the patient is diagnosed of COVID and the family members, you do the testing, and then what are you going to do with the positive comes in? Are you going to treat them? Are you not going to treat them? Those patients probably I don't treat them because 80% of them, almost 65, 70% of them, they will not develop any overt symptoms.
Yeah.
So I'm not too concerned about that. I'm mainly concerned about the patients that have even minimal symptoms. Just get the CBC with differential and other labs it's available, and then start the steroid. Wait for it. So there is absolutely monitor them the hypoxemia, monitor the lymphocytopenia. Those are the things, that simple things that we can do, very economical, especially for our society. Maybe not everybody can afford to have a tocilizumab or remdesivir or anything that, I don't think.
Even
So,
thermometer. Because but they do know one thing, they have most likely 80% have a contact source. They can tell. That is very, very valuable tool. If the patient saying, oh, I have high suspicion, you have these 5 symptoms, you start the steroids. So I mean, all the protocol, it's not the steroids, the drinking water, walking. It is maybe both speakers saying both steroids and thrombolytics or some kind of anticoagulants, but you need a doctor to advise that. So it's all telemedicine treatment we have. That's what. Sir, any other questions? So please.
I think not much, but see, any guidelines will come up in this particular topic. I think we are expecting some sort of a guidelines like as a published evidence. Something will be coming up soon.
No, we're requesting. I think Suresh, you were publishing studies, right? Your case reports.
I'm trying to publish. Working on up to finishing.
Make it soon.
We'll see. We'll hope.
Yeah, we need to make it faster because I am writing personally letters with the proposed to the governor of here in Michigan, and we're trying to push that. And also if the ICMR, if anybody who is listening, if IMA can help us, we're going to RP letter to IMA, can push to bring the awareness to the ICMR. That's my request, because we have more luck with ICMR than CDC and WHO. I can guarantee on that. And because our poor people and patients, they're very, very, they need it, and the situation is not good there.
I could see Dr. Lokesh giving the answers almost immediately on the chat box. So there is he is giving the answers to them. I think most of the things have been answered. The questions that are coming up.
Vijay, do you have anybody raise a hand or something?
I didn't follow it.
Oh, Vijay said somebody raised the hand in the computer.
Okay, Vijay, I think she has to take care, and okay, if somebody raises, okay, just see.
Yeah, there is one, Chandramouli.
Okay, go ahead.
Hello.
Yeah,
very lucid presentation, Dr. Suresh. I respect all the people who have today participated. See, the problem is from 1 to 7 days, the bilateral pneumonia is occurring around 6th to 7th day of the illness.
Sure.
People are waiting. So I have got a case, now I tell you. The first day, the Corticosteroids PCR was negative. On the 7th day, they developed breathlessness. Even in the first time when they went, there was a lymphopenia. Is there any guide that we can interfere, like giving low molecular heparin, like giving steroids? I think you have cleared. That's fine. Is there any guide other than this RT-PCR? Because it was negative. Today they have come with a dyspnea. Today they have gone to the hospital. So any, practical way that we can guess it, any investigation or anything. Should we wait till the pneumonia is developed? Till breathlessness is developed?
Absolutely not, Chandramouli Garu. I want to address you. What you mentioned here is, remember, there is a lymphocytopenia when they came in first. That is a telltale sign. You don't need to be the positive test. He has a lymphocytopenia at this stage, lymphocytopenia patient with coming in. You need to start treating with the steroid. You don't wait until 1 week to get the.
Yeah.
And
Yeah.
as far as the anticoagulation, I'm not too concerned about the anticoagulation unless you're seeing the D dimers elevated. If the D dimers started going up, then we can start doing the anticoagulation.
Well, every day we should do, or every day we start steroids.
I will.
Okay. And then how will you go with the investigations, like, you know?
I will do the CBC differential every day if possible. If not,
Okay.
and I will do the D dimers. If it is started elevating, then I will do every day. Otherwise, you don't need to do it every day.
Yeah.
Once you start on the anticoagulation, you probably can do it after 3-4 days. But I will follow definitely CBC with differential and liver enzymes, electrolytes
Every day.
every day.
Every day.
Okay.
Okay.
Thank you, doctor.
Next
Vidya,
person,
anyone?
can you open next
Thank you,
person?
doctor. Thank you very much.
Okay.
Vijay, next person.
I think
We have Dr. Saraswati Mupana.
Yeah, you can open. Can you open, Saraswati, unmute? Dr. Saraswati, can you go ahead and talk?
Hi, good morning, everybody. Thank you very much for the excellent talk. I practice pulmonary critical care in Massachusetts. So we are actually seeing the number of cases have come down here, but I'm seeing a lot of outpatient pulmonary patients, really elderly, more than 80 plus, among all other patients age groups as well. My question is, what I'm seeing now is either suspected or positive COVID-19 patients who went to the primary care, I mean, beyond the days. It's not like day 2 or day 5 or day 7 when we can think about steroids, right? They're coming beyond all these days and maybe a couple of weeks later also, but still have this exertional desaturations. So I've been starting them on the methylprednisolone, right? And my question is, do you all have any experience, just like what Dr. Janaki was saying? She said she was also seeing more of such patients. So I was just wondering if anybody has experience in the long-term outcomes or the long-term factors, and if there is a benefit of steroids in these patients. I believe there is, so I am using them, but I want to know what other speakers' experiences and for how long would they do it. I started a few cases last week.
You are the expert. You are the pulmonologist. So go ahead.
But I want to share from others too, right? Learn from others.
Answer that question.
Actually, I did not present this time because Janaki Garu presented pretty good evidence of elderly patients that are in the hospital. My first patient or the first 2 patients is a family of 84 and 86-year-old. They treated with, they came with almost 1 week later, the symptoms. They were treated at least, I think 4 weeks. Actually, initially treated 1 week because of the elderly, and also one of them were diabetic. I stopped. They were also started having symptoms. Then I extended them for 3 to 4 weeks. They did very well. And another thing that you can also suggest is most of these patients, even after treating 3 to 4 weeks, don't let them exert too much because the symptoms last for a longer period. So make sure that they take an first and regular activity, not strenuous activities, to let them in the elderly, especially after the 60 years old. If they are more than 60-year-old, make sure they be careful with too much of exertion once they recover.
And we also, I think we have 300 people attended. We want to 300 people tell 300,000 people and let them decide, because we need the awareness campaign is more what we need. And this question about nebulizer, that's for asthma. I think we don't recommend any nebulizer because it will aerosolize unless in the patient.
Aerosolize, yeah.
Aerosol.
Yeah.
I think anything else? Otherwise, I think it's a lively, really good webinar. I think after a long time we have been listening to almost some webinar almost every day. But this is a really practical webinar what we had. I think everybody, the movement of chart that has come itself, it shows that how many people have attended and how they are interacting with every one of us. So I think my thanks goes to all of you, I think especially
Yeah,
Dr.
told-
Janaki,
This is for
Dr.
you, sir.
Sudesh, and both and that Lokesh for making this such a lively webinar today. And really, every one of them, they enjoy. I could see on the chat box all the things coming up. So I think before we wind up, I think few words from Lokesh and other people.
We'll work first. Janaki garu, can you give your closing statement?
Yeah, as I was speaking, the pulmonologist was saying steroids, she started on the elderly patients. Right now, my situation there, giving patients who are now reactivating. So I'm giving steroids now. But at this point, we don't know what is the end point. Where do we stop the steroids? Does the pulmonary picture get better? Or we are going to keep having these storms? These are questions will remain. I guess, maybe I stop the steroids after 3 weeks, the patient will not have any more storms, then we are good. But what happens if it continues? So we really have to wait and watch for this role of steroids, or there is any other medication which will come up to stop these kind of storms in elderly patients. So ultimately, the steroids have a role in the treatment of COVID-19 infections. So I think this is a great discussion. I enjoyed thoroughly. Thank you all.
Suresh?
There is the main question that many people asking about it is, there is not much literature in the steroids. So why should I use? My answer to them is, there is not, the disease itself is about 4 or 5 months old. There is not much information on any drug. And we are using every other drug with high confidence, including interleukin-6 antagonist, and also the remdesivir, which is probably the study was done only 20, 30 patients, and it's not even prevented even the death rate. So my question is, one should ask and understand, what are we treating it here? It's an unknown territory. It's an unknown disease. It's the beginning of the disease. So we should think about what is the practical things that we can do. What is that is happening in the body? So address that. So I really don't want every one of you to worry about what happens to the steroids. And if you do not use the steroids, the inflammation part, if you don't control it, it's not going to control. We'll be seeing. And plus this very cheap and inexpensive drug that we can deal with. I forget about all the inhibitions. Try to work on, start early in the course. That's the only treatment that we can see at this time until we find a standard treatment that is available.
Like vaccine.
The last question is it the same protocol we follow in pediatric group also?
Absolutely.
1 milligram per kg in divided doses.
Okay.
Absolutely. Can you? Let me close myself. So thank you so much. We will keep continuing this campaign. We started 3 months ago. I think it's just one of the initiation, and we really appreciate it. We're thinking about how a small person with no money, if they get a COVID, maybe an auto worker. Now the shared autos. I'm worried about how many auto drivers will be getting it. What kind of treatment they can be available? What can be treated? They have only clinical. You have only few drugs. They don't have any oxygen. So that's what our thinking process. We keep continue to through the journey what we can as little as we can. Thank you so much for all the.
I think I thank every one of you plus Vijaya. Because she is backbone again doing all this from the office. So Vijay Kodali for doing all this job and taking every one of us to enjoy this particular webinar today. Good night to all my friends in India, and enjoy your day in US, all my friends in US. Thank you very much, and we look forward to again have some sort of something like a fruitful this sort of a webinar in due course of time.
And also thanks many speakers. We know Kameshwar Garu, Rakesh Garu, Chakra Garu, so many people joined.
Yeah, a lot of people have joined. I cannot
we're requesting ISA to do the webinar there with them in the future with API, and then we have a lot more to do. We just even not scratched about awareness. Suresh, can you close off the meeting, please?
Yeah, thank you. Thank you, Lokesh, Dr. Dwaraknath Reddy, and the speakers, Dr. Suresh Anne and Dr. Janaki. This is an amazing experience, and thank you, the local IMA president, Dr. Vijayendra Reddy. And Lokesh has been the backbone, and he has been, he has a passion. The COVID, I don't know what he'll do after this COVID is gone.
No, this is only temporary, a lot more.
But he's a backbone, and he has brought up so many. We have done so many webinars, and I think almost all of the RP members and maybe some physician in India are all earned PhDs in COVID management right now. So we did a great job. RP has done a great job in public education. We have educated so many Indian audiences in the United States. And thank you again for joining. And I have a special invitation for all of you. We are organizing the first virtual summit organized by API starting next week, and it will go on for 10 days. We have great entertainment, we have great education, we have great fun. We'll be having medical students doing the medical quizzes, spelling bee on medical terms. So many events, medical related events going on. Please join us. The registration is free, and you have to go to API website at www.aapiusa.org and register yourself for free. For non-members, it's a nominal fee. For Indians living in India, we'll have a different pricing for them, but it will be very nominal. Please join us. The most important part is API has taken up this cause of global medical education this year, and Dr. Lokesh Idara is the chair of that committee, and we have done an amazing job this year educating especially on this COVID. Thank you so much. Thank you all for joining, and special thanks to Vijaya Kodali. Vijaya Kodali has done amazing job. She is our office manager from Chicago headquarters, and she's not only, she's everything. She's a secretary, a boss, she's an administrator, she's a IT person, and she does everything. She's a superwoman. Thank you all, and have a good day, and please join us next week.
One last word, because I should thank all my IMA colleagues over here they for joining us, and also Dr. Vijayendra Reddy for taking his time, because tomorrow he is busy in several things, because he has to go and meet the governor. There is a call from here for him for a similar situation. So I thank every one of our colleagues over here who has joined this particular webinar. Thanks a lot again. See you all soon again.
And last but one, we're going to start probably global association of medical students of India. So that's what we're planning. That's going to be. Thank you so much. Good night in India. Good morning here. Thank you.
Okay. Bye bye.
Right.
Right. Vijay, thank you. Vijay, closing down.
Yes,
right.
thank you.
Thank you. Bye.